Hi friends, welcome to all of you who are tuned in to this channel. So in this video I'll be discussing the biomarkers of hyperglycemia, how we do the diagnosis of hyperglycemia, which is also known as diabetes, and what are the different biomarkers for the prediction of it beforehand. So in this lecture, we'll be covering the objectives which are enlisted here. Hyperglycemia, the types of hyperglycemia, also known as diabetes mellitus, what are its types? Then biomarkers, what are they, and how we use different types of biomarkers for diagnosing as well as predicting the diabetes mellitus in human patients. Hyperglycemia is actually defined as the dysregulation of the glucose levels above the normal levels in a serum. So it is manifested as the sustained high levels of glucose in a patient. So it serves the hyperglycemia serves as the classical sign of the disease known as diabetes mellitus and as a pivotal prerequisite for its diagnosis as well. The dysregulation is actually from the normal values, and if it goes down it's called as hypoglycemia, while as in the diabetes mellitus the glucose level in the serum goes above the normal level, so it will be referred to as hyperglycemia, increase in the glucose levels of the. This is the diagnostic feature as given by the WHO and ADA, how we can define the hyperglycemia and use it as the diagnosis of a disease. For the diabetes, the criteria is when the fasting glucose levels in the serum goes above and beyond 126 milligrams per deciliter for the diabetes. Whereas for the impaired fasting glucose, it ranges between 100 milligrams per deciliter to 125 milligrams per deciliter. And there are some symptoms of the hyperglycemia which can help in the diagnosis of the diabetes as well. So the hyperglycemia, also known as the diabetes mellitus, is a chronic lifelong disease which is usually progressive in nature and affects the multi-system organs, is classified as heterogeneous metabolic disorder because it affects the whole metabolism of a patient which is affected by it. As it has complex pathogenesis, the foremost and the best diagnostic feature, as I already covered, is the persistent hyperglycemia. Then there is a combination of abnormalities in the metabolism of all macromolecules, carbohydrates, fats, as well as proteins. And the defect actually is a manifestation of the insulin secretion. There is a defect in the insulin secretion or insulin action or both. So the hyperglycemia is there. There is a dysregulation of the insulin levels, and then there is an abnormality of metabolism of the macromolecules. However, clinically, the hyperglycemia, together with the clinical symptoms of polyuria, polydipsia, and polyphagia, are the gold standard of diagnosing the diabetes mellitus. Diabetes is further classified into 5 different types depending upon its effect and its pathogenicity. First is the type 1 diabetes mellitus, which accounts for 5 to 10% of the cases worldwide and is autoimmune in nature. It is manifested because of the destruction of the pancreatic beta cells. Then there is type 2 diabetes mellitus, accounts for 90 to 95% of the cases and is characterized by deficiency of insulin or its resistance by the peripheral organs. Then third is idiopathic, which affects mostly Asian, Caribbean or African people. Usually has the varying degree of beta cell dysfunction. Fourth one is affecting the pregnancies. Around 14% of the pregnancies get affected by it and is classified as gestational diabetes mellitus as it occurs during the second or third trimester of the gestation. Fifth and the last one is called as secondary diabetes mellitus, and usually accounts a small percentage of the cases, around 1% of it, and associated with specific conditions and pathologies which have been classified apart from these four things. So what are biomarkers? Biomarkers are the characteristics which can be metabolite, biomolecule, anything which can be measured and evaluated for the indication of three things within the individual in which it is measured. Either it can measure the normal biological process, it can measure the pathogenic process, or the pharmacological response to certain drugs, so certain therapeutic interventions. Nowadays, the biomarkers are chosen in such a way so that they will be able to measure all three. Uh, Essentially, a biomarker should be able to measure and quantify the biological parameters which it is measured, and then it can serve as the index of health for the related assessment as well. Essentially, when a biomarkers are chosen, they are chosen based upon certain characteristics which should be inherent to them. There are so many characteristics which a biomarker should possess, but four of them are important in choosing them for the diagnostic purposes. First and foremost is it should be specific. The biomarkers which are chosen should be specific to a specific disease. In turns, it also mentions that it should not be able to detect something which is not related to a disease. That is, it should not be giving us false positive results. Then it should be sensitive enough to pick up a smallest change. It should be precise in diagnosing that earlier cases of the disease as well as detect the minor damage. So it is reflected in no false negative thing also. So it should be sensitive enough so that it will pick up the change and tell you that it is disease condition. Then there is prognostic feature. The biomarker should be directly related to the disease. Its levels in the serum, if you are measuring it in the serum, then its levels, its strength should be equal to that of the extent of the disease. Greater the disease, greater should be the value of a biomarker in the plasma, and hence its prognosis. Then it should be able to persist long within the individual so that we can be able to pick up it from the blood or any other fluid and then analyze it for the diagnosis. And it is important for the delayed admission also. If there is a delayed admission of the individual and we need to look for the biomarkers, those biomarkers are chosen which persist around 1 day to 2 day or 3 day, which makes it a good biomarker. For the diabetes mellitus, there are certain different kinds of biomarkers. These five biomarkers for the diabetes mellitus are enlisted here. Two of them, which are traditional, are the glucose and the glycated hemoglobin, which are most frequently used for the diagnosis of the diabetes mellitus. And the new innovative ones are the fructosamine, glycated albumin, and 1,5-anhydroglycatol. So shedding some light on the use of glucose as a primary biomarker for the diagnosis of a diabetes mellitus, we know that is the chief end product of the carbohydrate metabolism in humans. And in diabetic patients, it is usually displayed as higher blood glucose level, hyperglycemia. And we can measure it by two different ways, either by fasting plasma glucose or postprandial glucose, or both. Fasting plasma glucose is the one which is classically used, and nowadays it is used for the self-monitoring purpose as well. And the threshold or the criteria which is given is greater than equal to 126 milligrams per deciliter. And there are three scenarios which can happen in measuring the FPG. Is that it can be below 100 milligrams per deciliter, which is the reflective of normal condition. Then there is a borderline, which is also called as pre-diabetes or impaired fasting glucose. where the levels are greater than 100 but less than 126 milligrams per deciliter. And the third condition is when the FPG is above, consistently above, greater than 126 milligrams per deciliter. If the levels are greater than 126 milligrams per deciliter for a repeated tests, then we have to do the diagnosis of a diabetes. This is the classical way which we follow in the diagnosis of the diabetes. Another test which is done for the clinical diagnosis of the diabetes mellitus in conjunction with the FPG is the oral glucose tolerance test, OGTT. It is performed on the patients after an overnight fast of at least 10 hours, and we give them orally afterwards 75 grams of glucose, and then measure the blood glucose for every 30 minutes for at least 2 to 3 hours. Usually 6 samples are taken for the diagnosis of diabetes mellitus. And what are the different levels? There are again the three scenarios for the OGTT, and the threshold is here greater than equal to 200 milligrams per deciliter for the diagnosis of a diabetes. Both FPG and OGTT are relatively easy to perform because of their requirement of less skill and infrastructure. OGTT also gives us the information about how well body responds to a challenge thrown to it by giving the 75 grams of glucose, hence the tolerance test. However, they both are able to give us the glycemic control over a single day only. This is their shortcoming, and their sensitivity is also affected by many factors like blood collection, the storage of it, and then the technical skill of the technician who performs it, then the method of detection as well. In order to overcome the limitations of the FPG and the OGTT, another marker which is used for the diagnosis of the DM is the glycated hemoglobin. It is an isoform of the hemoglobin which is utilized currently for the detection and diagnosis of the impaired fasting glucose and impaired glucose tolerance. Actually, the glycated hemoglobin has four isoforms: HbA1a1, HbA1a2, and HbA1ab, together with the HbA1c. All these four make a glycated hemoglobin fraction. As you can see in the right hand side of the picture, these glycations happen in the hemoglobin, and when the hemoglobin gets glycated with the help of the glucose, then different isoforms of the glycated hemoglobin are formed. Together they make up almost 6% of the total adult hemoglobin. HbA1a, 1b, and 1c differ in the type of a glucose which is associated with the valine residue of the hemoglobin. For HbA1a type, it is fructose 1,6 bisphosphate. For 1b type, it is any carbohydrate. While as for the HbA1c, it is always glucose. Hence, this HbA1c fraction is utilized for the detection of the hyperglycemia and hence diabetes mellitus. So HbA1c concentration is actually directly dependent upon the lifespan of the erythrocytes as well as on the blood glucose levels, and it measures the long-term glycemic control, and hence is the gold standard nowadays for the reflection of the chronic hyperglycemia. So for the diagnosis of the hyperglycemia, in particular for diabetes or pre-diabetes, the ADA criteria are given as: for the diabetes, the levels should be greater than or equal to 6.5% of the total HB, and levels in between 5.7 to 6.4% of the total HB. For the HbA1c is regarded as pre-diabetes. So the normal values are always below 5.7. Furthermore, there is another thing which we should remember about the HbA1c is that only 50% of the HbA1c is giving us the previous levels of 30 days, and only 10% is reflective of the story of the glycemic index of 91 to 120 days. Usually clinicians tend to tell patient that HbA1c is reflective of previous 3 months, which is not true. Only 10% of it is reflective of the previous 3 months, while as 50% of it is reflective of the previous 30 days. So it is better to rely on this index, that HbA1c tells us the glycemic control of the patient for previous 30 days. Another important limitations of the HbA1c is its lack of ability to reflect the postprandial and fasting hyperglycemia. It cannot distinguish between the two, and it will not tell you the story of these two things. It will just give you the index of the glycemia over previous days of 30 or 90 or 120, whatever you want to see. Then also that HbA1c is not a good predictor. It's a poor predictor of cardiovascular disease, which is the function of FPG and OGTT. This is another limitation of the HbA1c. This slide provides you the information of the context between the three biomarkers which are used for the diagnosis of the diabetes and impaired fasting glucose, and the levels set by the World Health Organization and American Diabetic Association. There are certain pros and cons of HbA1c for using it as an exclusive biomarker for assessing the glycemic control. Here you will see the most of the pros are listed here. The important one is that there is no prerequisite of fasting for doing the HbA1c test, and it can assess the chronic hyperglycemia. It is better in specificity than the FPG, and it is not perturbed by the diet, stress, or exercise. These are most of the pros which are in favor of HbA1c to be used as a gold standard for the diagnosis of the glycemic control in conjunction with FPG clinically. Moving further in the lecture to the second part of this lecture, focusing on the innovative biomarkers which are currently being utilized in endocrinology for the diagnosis of the hyperglycemia and diabetes mellitus in particular. One of the best biomarkers lately introduced is the glycated albumin. Glycated albumin is produced from the abundant protein albumin which is present in the serum of the humans. It is produced by the reaction between the glucose and albumin, arginine, lysine, or cysteine residues with the help of a non-enzymatic oxidative reaction to form glycated albumin, as you can see in the accompanying diagram. The glycated albumin is produced in directly proportional to the serum concentrations of the glucose. So as the serum concentration of the glucose will increase, glycated albumin quantity within the serum will also increase, and hence it is a direct prognostic biomarker for the reflection of the glycemic control for a shorter period of time, only 2 to 3 weeks. Why only 2 to 3 weeks? Because albumins in itself have a shorter life of only 15 days. Further, when we compare it with the HbA1c, because it is similar to that of the HbA1c glycated hemoglobin, in relation to the glycated hemoglobin, glycated albumin serum concentrations are usually 3 times more present in the hyperglycemics. So it can be said that they are more sensitive to the change in the levels of glucose in the patients. Furthermore, it is seen that hemoglobin resists the glycation, whereas the glycated albumin is more sensitive to this process. So it becomes more quickly available for the diagnosis, and hence the rapid responding to the indication of change of glycemic control. Hence, because of these properties, glycated albumin has an advantage over other biomarkers which we just went through in monitoring the glycemic control primarily. Why? Because it is not influenced by the erythrocyte lifespan as is HbA1c. It is not dependent on any variant form of the HB. It is directly glycated albumin, whereas the HbA1c is only one of the 4 variants of the glycated hemoglobin. It is not also influenced by the anemia, as HbA1c can be affected by the anemia as well. And there are other conditions like pregnancy, liver cirrhosis, and neonatal DM, which can affect the other biomarkers but not the glycated albumin. So now there is a choice for the endocrinologist what to choose. If you want to choose the blood glucose levels within a short period of time you have to monitor, then you can choose the blood glucose level in itself, like FPG, OGTT. If you want to see the glycemic control over 2 to 3 weeks, then you can choose glycated or glycated albumin. And if you want to choose the glycemic control over a period of months, then glycated hemoglobin is the choice. So the choice depends ultimately on the clinicians. So moving further, the glycated albumin provides the index for recent glycemic events, as well as I have already told you, within 15 days. And it is more useful in assessment and monitoring of those patients which have fulminant type diabetes mellitus, in which the glucose concentrations fluctuate between higher and lower values rapidly. So you can utilize the glycated albumin over the glycated hemoglobin. And it is also useful in predicting the progression of diabetes complications and comorbidities. There is another part which is important in mentioning the advantage of glycated albumin over the glycated hemoglobin is that you can monitor the titration of the dosages of the pharmaceutical interferences. Like for example, if the patient is on the hypoglycemics, it is better to monitor the glycated albumin because it responds quickly and it will give you the response time over 15 days rather than the glycated hemoglobin. So the choice also here is of clinicians again. So it is better to choose the glycated albumin if you want to monitor the weeks time of the glycemic control rather than months. Another innovative biomarker is the fructosamine. Fructosamine is similar to that of glycated albumin. It is a ketomine. It is also formed by glucose or fructose reaction glycation with the amino group of the proteins, all proteins. So it includes all glycated serum proteins. It has a shorter lifespan and it can assess the evaluation of the blood glucose levels for previous 2 to 3 weeks, similar to that of glycated albumin, and it is reflective of recent changes also in the glycemic control up to 15 days. It is preferred nowadays. Why? Because it is cost effective and easier to perform in comparison to HbA1c as well. So what is the advantage of utilizing fructosamine over other biomarkers, especially over HbA1c, is specifically reflected in those DM patients who have fluctuating glucose levels but with stable HbA1c. So if you utilize HbA1c only in these patients, you will not be able to ascertain whether the glycemic control is good or not. So we can utilize fructosamine over a period of 1 week only and be able to tell whether the glucose is fluctuating or not and whether there is a good glycemic control or not. Secondly, in the same patients, it can tell us about the microvascular complications as well, which is not the function of the HbA1c. This is the limitation of HbA1c also. Thirdly, is that it is a good indicator of the glycemic control in chronic kidney patients who are suffering from chronic kidney disease, especially the patients who are stage 3 and stage 4. However, it does have some limitations. One of the important limitations is that it represents only a fraction of the total glycated serum proteins, which are about 10% only. So usually it is not recommended in those patients who have serum albumin concentration lower than 30 gram per liter. Another important innovative biomarker these days utilized for the diagnosis as well as the monitoring of the glycemic control is 1,5-anhydroglycol. 1,5-anhydroglycol or 1,5-AG is a deoxyform of glucose. Under normal conditions, it is usually filtered via glomeruli at a rate of 5 to 10 grams per liter. But under these conditions also the plasma concentration remains static around 12 to 40 micrograms per milliliter. In hyperglycemia, what is seen is that tubular reabsorption of this compound 15 Ag is inhibited, due to which this plasma concentration will decrease drastically, and hence this decrease can be reflective of the glycemic control as well. So 15 Ag plasma levels are inversely related to the plasma glucose levels. It is usually stable and reproducible and cost effective, and hence it is used in comparison with other glycemic biomarkers, and has an advantage of reflecting the glycemic control within a retrospective period of 10 to 14. Here you can see the comparisons between the different biomarkers that are utilized for the diagnosis of the diabetes mellitus, ranging from the glucose, HbA1c, glycated albumin, fructosamine, and anhydroglycol, and their particular sensitivity and specificities. Moving to the last section of this talk is the predictive biomarkers. What are those? They are the markers which are sensitive enough to be detected at an early stage of the disease. Hence, they help in predicting the risk of disease in a population, and they are useful in developing personalized medicine, which can be utilized as preventive or proactive therapies. Numerous recent studies have given us the different kinds of biomarkers in terms of their expression within the human body. And some of the novel biomarkers which are used as predictive biomarkers are microRNAs, proteins, numerous metabolites as well, which are specific to the pathology of the type 2 diabetes mellitus or their related complications. You can see on the right hand side of the slide the potential pathways which can serve as the biomarkers for the prediction of the diseases. These range from the metabolic intermediates, metabolic molecules, or some gut permeability or endotoxic molecules, or pro-inflammatory cytokines and inflammatory molecules, or epigenetic or genetic regulators, as well as via metabolic effects of the T2DM as well. All of these can serve as the predictive biomarkers. Ability of a microRNA to be utilized as the predictive biomarkers for the diagnosis of various disease, especially here in case of hyperglycemia or diabetes mellitus. It is well established in literature, and one can check so many of microRNAs are currently being studied for the diagnosis purpose. MicroRNAs are actually the small 20 to 25 nucleotide long non-coding RNAs molecules, which are utilized for the regulation of the expression of certain mRNAs. They bind to the mRNA and regulate their expression. They are emerged nowadays as potential biomarkers for the type 2 diabetes mellitus and its related complications as well. Almost 50 different types of microRNAs have been studied and associated with the out of these 50 well-established microRNAs, some of the important microRNAs which are seen to be associated with the diabetes mellitus are, like, for example, MIR103 and MIR143, which are shown to regulate the subcutaneous adipose tissue and development of T2DM and can be utilized as a predictive biomarker. Then the expression of particularly 5 different kinds of microRNAs has been shown to increase the diabetes mellitus risk, so you can use these as well as a predictive biomarker for diabetes mellitus, as well as MIR126, 320, and 503, which have been shown to be involved in diabetic cardiovascular disease and endothelial. Another type of predictive biomarkers which I have already told you are the proteins of an individual. A number of different kinds of metabolic proteins, both structural and dynamic, have been studied and have been associated with the type 2 diabetes mellitus and its related complications. In the panel, you will see the blue and the amber region. The blue region contains those proteins which are upregulated in T2DM, and the amber will show you those proteins which are downregulated. So they are related directly to the diabetes mellitus and can be utilized for the prediction of the disease as well. And finally, the metabolites can be utilized also as a prediction or as the predictive biomarkers for the hyperglycemia and the glycemic control as well. You can see in the panel there are the different metabolites or intermediates of three different kinds of metabolisms that take place in an individual, and all of these can be utilized together with the bioinformatics to ascertain the prediction within an individual to develop diabetes mellitus or not. In the green, the metabolites of the carbohydrate are given. In the amber, the amino acid metabolic intermediates, and the blue contains the lipid metabolic intermediates. All of these can be utilized for the prediction of the disease and its progression as well. So this was all about the biomarkers and how we can utilize them for the diagnosis of the glycemic control in diabetes, as well as for the prediction of the diabetes. I hope you enjoyed it and it was beneficial. If you like the contents of the video, you can order the book Molecular Biology and Biotechniques from Amazon. It's available both in Kindle and paperback format. And do subscribe to my channel for further videos which I will upload in due time.